Hi, my name is Marat Fudim. I'm a cardiologist in heart failure here at Duke University in the United States. As part of the Pan-NASH initiative, I will be talking about the link between NAFLD and heart failure, a cardiology perspective. Here are my disclosures. So let's start with discussing the problem at hand. The problem at hand is that non-alcoholic fatty liver disease is highly prevalent. Anywhere between 25 to 50% of an individual continent have been linked to have prevalent non-alcoholic fatty liver disease. It obviously varies globally from region to region, but those numbers are simply staggering and obviously driven in large degree by the obesity epidemic, the diabetes epidemic. And why is it relevant that NAFLD is A, on the rise, and B, highly prevalent? Well, because NAFLD, which is a very broad term that encompasses various degrees of liver disease, but if we assume that a benign steatosis, the benign fattening of the liver, person, let's say 25% of the population, problem is that a significant amount of those patients progress then to NASH, so non-alcoholic steatohepatitis, and then develop some various degrees of fibrosis, which can progress to cirrhosis, which might or might not be reversible at that time point, and might require a liver transplant, stuff like that. So you never want to even get into the vicinity of that. But what does a cardiologist care now about it? So I'm going to give you the cardiology perspective on the interlink between NAFLD, non-alcoholic fatty liver disease, and heart failure. Well, the problem is that many of the risk factors that lead to NAFLD, such as the metabolic syndrome, hyperlipidemia, but also the consequence of an affected liver that might infect global systemic activation of the inflammation system, might also change the factors that are produced by the liver, either adversely in most cases, actually lead to the key components that will then affect the cardiovascular system. One, insulin resistance tends to go up. So you have a greater propensity to the metabolic syndrome and diabetes. You are more pro-atherogenic. You're more likely to develop coronary or peripheral vascular disease. You have global systemic inflammation, and you are more likely to be hypercoagulable. You're also more likely to have, due to the NAFLD, greater systemic hyperactivation of the vascular system. So you have actually more arterial hypertension. So all of those things together increase the propensity for cardiovascular downstream effects, which then have been linked individually to these components. So the risk of CAC, so coronary disease, is actually going up. So it has been clearly described the association with left ventricular hypertrophy, valvular disease, and the incidence of arrhythmias and heart failure. When one looks into the incidence of heart failure, we published on that actually recently, what we found is that the incidence, so the new onset of heart failure, whether that is heart failure with reduced or heart failure with preserved ejection fraction, this setting, we didn't even look at that. But what we looked is that if you have no NAFLD in the registry, those were global registries, Asia, Europe, and the US, we found that the new onset of heart failure was about 60% in subsequent 5 to 10 years. That is a lot of new onset heart failure because the prevalence of NAFLD is so large. Let's say it's 25%. You can do the math. Those are millions and millions of patients to develop heart failure as a result of NAFLD. The interesting thing is that in a subsequent analysis, we found that these patients are really, in most cases, HFpEF patients. That was a separate talk I prepared on that, is that, to establish the link between NAFLD and HFpEF, which really HFpEF is primarily the disease within heart failure that is driven by NAFLD. All right. So, and that comes to this point is that we now know that although right now heart failure with preserved ejection fraction, HFpEF, or heart failure with reduced ejection fraction, HFrEF, are making about 50-50 of the US heart failure population, but also globally is probably true as well, that will shift to be a 70-30 predominance of heart failure with preserved ejection fraction. And I would argue that majority of that is driven by NAFLD and the obesity epidemic. I don't want to go too much into the detail about phenotypes, but let's be very clear that not every NAFLD-induced heart failure patient comes alike. Heart failure is an extremely heterogeneous disease. but identifying that there's concomitant liver disease, or maybe liver disease that's driving heart failure, might be very important, because we believe, when we publish on that there might be several phenotypes of heart failure, specific heart failure with preserved ejection fraction. We refer to them as the obstructive, the metabolic, or the advanced liver disease phenotypes, which all of them, while you want to target the liver and treat the liver disease at the same time point, I think the degree of liver and heart contribution at that time point vary dramatically. Again, a plug for the fact that we cannot ignore the concomitant obesity and a metabolic syndrome that are driving both NAFLD and heart failure. Thus, to no surprise, later when we talk a little bit about management strategies for non-alcoholic fatty liver disease and heart failure at the same time, is that many of the treatment modalities that are found to be successful or are believed to be successful are really not targeting the heart itself, or maybe not even the liver itself, but rather the metabolic syndrome, so the hyperlipidemia, the systemic inflammation that are leading, or are the fuel that are lighting up the fire for both of those disease states. So focusing on comorbid disease is very important for both NAFLD and heart failure. So, here I'm going to try to provide you an interesting perspective on screening. As a heart failure cardiologist, I do see patients with heart failure on a regular basis, yet liver screening is often not one of our priorities. Yet there's been pretty good guidelines recommending that even the primary care setting, patients at risk, such as patients with an age of greater than 50 with diabetes or other features of metabolic syndrome, should be routinely scanned with a liver ultrasound and also looked at from a liver enzyme standpoint to identify high-risk pattern. The interesting thing is that in most cases, at least in my practice, or in a cardiology practice, we usually stop at this time point. If we to identify elevated liver enzymes and or fatty liver on ultrasound, or even cirrhotic liver, at this time point, we tend to refer the patient. Having said that, with a prevalence of 25% of the US population alone, if we were to send every fatty liver to our liver doctors, they would go crazy. They do not have that bandwidth to take care of that many patients. So actually, the guidelines recommend that you risk stratify the patient further and obtain at least a non-invasive risk score of fibrosis, such as the NFS or the FIB-4 score, which using biometric and laboratory data allow you to risk stratify the patient whether they have low, intermediate, or higher risk for high-grade fibrosis, and then only refer those patients to liver disease centers in the setting of high-risk fibrosis. Why do we care about high-risk fibrosis? Well, there's a very clear linear relationship between the degree of fibrosis, F0 being none and F4 being the highest grade of fibrosis, and clinical outcomes. Here we're talking about death, so survival. So as you can see, patients with a high degree of fibrosis, F4, have the worst outcome by far. So that's the risk stratification that could be done up front. Whether that is implemented in the clinical practice, I highly doubt it, that the understanding of risk prediction for liver disease is appropriate. As a matter of fact, I would argue that the use of screening in the setting of cardiology practice is highly underutilized, and a lot more education needs to go into why it is important to identify and screen for liver disease. What would you do once you identify a patient with liver disease? Well, the recommendations are not that different than it is with patients with heart failure, especially heart failure with preserved ejection fraction, where we focus a lot on concomitant disease, such as comorbidity. So here, we recommend to increase the alcohol intake. We recommend to lose weight where possible using a low-fat approach, a low carbohydrate or high ketogenic diet approach. I mean, there's many different ways to target from a lifestyle intervention, both non-alcoholic fatty liver disease and HFpEF or HFrEF. But it's important that these are the foundational cornerstones of the heart failure treatment and NAFLD treatment. So you need to have that implemented always in parallel. And then we often resort to pharmacological therapy. But here it's important to acknowledge, really to date, we do not have approved therapies for the management of non-alcoholic steatohepatitis and really beyond that are carrying a high degree of evidence. And to date, really, a lot of the pharmacological therapy is really focusing on the comorbid diseases we discussed. Some pharmacotherapy that carries a moderate level of evidence are the PPAR gamma drugs that are usually coming out of the diabetes space, but have been shown to affect non-alcoholic fatty liver disease as well. Antioxidants such as vitamin A have been also suggested, but again, carry only a moderate level evidence to support that. And then, of course, statins. Of course, statins are not targeting the liver in itself. They have pleiotropic effects, meaning they really affect inflammation, reduction of lipid levels, they reduce the coronary artery disease burden, et cetera, et cetera. But in the setting of NAFLD, there have been studies to suggest some benefit on NAFLD. I will end with this slide, really indicating that to date, we have some therapies for the space of NAFLD, but a lot more work is currently getting done to develop novel therapies that are targeting various forms of pathomechanisms, such as inflammation, such as fibrosis, such as lipid-altering therapy, such as insulin-sensitizing agents, that all of them, either standalone or in combination, will be coming to the US market or European markets in the future. So I think the future is very bright for the space of non-alcoholic fatty liver disease. It took the pharma industry a little bit of time to get to this point, but I think it has been recognized that non-alcoholic fatty liver disease is really a massive driving risk factor for a lot of diseases, but especially heart failure and cardiovascular diseases. I'll end on this slide where we will discuss the take-home messages. So non-alcoholic fatty liver disease and heart failure have an overlapping risk profile. I think that has been becoming abundantly clear over the last few decades. Further, there's evidence to suggest that NAFLD might precede the onset of heart failure. So NAFLD is not just associated with heart failure, but actually might drive the incident, the development of heart failure in itself. Thus, it becomes particularly important, not just for general practitioners or liver doctors to screen for non-alcoholic fatty liver disease, but also for cardiologists and heart failure cardiologists to screen for that disease. Why? Well, right now, we don't have that many dedicated therapies for NAFLD, but I can tell you that pipeline is filling up. There's a lot of novel pharmacological, non-pharmacological strategies that are targeting NAFLD. Interestingly, many of them overlap with the management of heart failure, because heart failure really at the end of the day is a metabolic disease. So metabolic strategies targeting NAFLD will also help heart failure as well. So I encourage the screening for NAFLD and then the consideration to enroll in clinical trials and really to get up to date on the clinical guidelines to treat and manage patients with NAFLD. Thank you very much. Have a good day.